So good evening, everyone. Thank you for sticking around tonight. I am presenting on behalf of a group of surgeons kind of across the US and Canada that got together to ask this question. None of us have anything to disclose today. So as we all know, bowel obstruction is a common emergency general surgery condition, of course, a condition that is treated by all general surgeons who take call. We also see on a daily basis, I'm sure in all of our practices, that the proportion of elderly in our population and our patient population is increasing. We know that by 2050, we expect that greater than 20% of the US population will be greater than 65 years old, and so this problem will not be going away. Along with that, more of these patients will be having increasing frailty with increasing medical problems. Frailty, of course, is a syndrome of physiologic decline and lack of resilience, and we often talk about this of lack of surgical reserve. Also, since the time of my training, and probably since the time of surgery in general, there's been evolving management of bowel obstructions. We originated with don't ever let the sun rise or set on a bowel obstruction, to knowing that most of them will actually resolve on their own if given enough time, but particularly 75% of them will resolve within the first day if they are going to resolve. More recently, we've added gastrographin challenges or bowel follow-throughs to determine who does or doesn't need surgical intervention if there's not a clear indication, and also just some time-limited gastric decompression with some decisions to go to the operating room. So how then do these two areas collide between the elderly patient and changing practice in small bowel obstructions? When should we intervene on the elderly, and particularly the frail elderly small bowel obstruction patient? Should we operate on them earlier so that we can avoid any further malnutrition that they may have or further decline physically while they're in the hospital? Or should we delay surgery at all costs and only proceed to the operating room if we have to? Or is there something in between that might be better? So we decided to look at the outcomes of patients who are 65 years or older admitted with small bowel obstruction and look at a segment of those defined with frailty. We did this by using a 2016 National Inpatient Sample, or NIS. We again looked for patients over the age of 65. We searched for ICD-10 codes for bowel obstruction. This is K56, anything in that family of codes. We did receive IRB approval through my institution at UC San Diego. And our primary outcome was inpatient mortality, secondary outcomes of time to surgery, hospital length of stay, and DC disposition, among some others. We determined our frailty, again, difficult to do in a large database set, by a previously published technique called the Colon Cancer Frailty Index, and you can see all of the characteristics that went into this coding algorithm. Each variable got 1 point, and the total points assigned to each patient was divided by 9. Any patient that had a score of greater than 0.27 was defined as frail for our purposes. Statistics you can see listed here. We looked at the data in a number of ways that we'll go through. As far as overall results, we had approximately 265,000 patients that were included. And since this is done in the United States, of course, the vast majority of them had Medicare. Of our frail population, we found 9%, or around 24,000 patients, and found more of them were women. Not surprisingly, they were in the bottom income quartiles, and more of these patients were transferred from other institutions. When we look at our unadjusted data, we see that the frail were twice as likely to die in the hospital, 10% versus 5%. They were more likely to go to surgery, but later than those that were non-frail. And their length of stay was, of course, longer than the non-frail portion. And of course, they were more likely to charge to a skilled nursing facility. None of this was very surprising to us. When we looked at our multiple logistic regression analysis, we found predictors of inpatient mortality were related to frailty, Black race as compared to white race, male gender, increasing age, lowest median income household quartile compared to the highest that we looked at, other or self-pay insurances, transfer-in status, and of course any of those undergoing operative intervention. And so we were a little bit surprised to see that a lot of the socioeconomic factors really do play out into the elderly population that we were focusing on for here. In our Cox regression analysis, overall we saw that the frail population were 20% less likely to go to the operating room. And then what surprised us is that the timing of going to the operating room for those who are the frailest and getting an operation was not associated for death in that population. But in our non-frail, so most of the comers of these elderly patients over 65, the longer we waited in those patients, they did have increased rates of mortality. So our frail elderly are more likely to die in the hospital waiting for surgery, likely from other conditions or a decision not to operate. Obviously, this is not able to be captured in this large database, and we're limited by that data set that we have. Our non-frail elderly were more likely to die in the hospital the longer they were waiting for surgery, but that timing was not a predictor for the frail elderly. And the frail elderly do overall have higher odds of mortality in the hospital. They're more likely to be discharged to skilled nursing facilities or need home care, and they're more likely to have to wait longer for an operative intervention if they receive one. So in conclusion, frail elderly patients with small bowel obstruction have higher overall in-hospital mortality, longer hospital length of stay, and longer wait to the operating room, although those that do have later surgery do not have increased mortality. We should be cautious, though, and realize that in all of our elderly small bowel obstruction patients that they should go to the operating room as soon as they are identified as that need. Thank you.